Hi, I'm Matt Galsky. I'm a medical oncologist at the ICANN School of Medicine at Mount Sinai and in the Tisch Cancer Institute. And at ASCO this year, I'm presenting results of a clinical trial, HCRN GU16257, which involved patients with muscle-invasive bladder cancer. The standard treatment for muscle-invasive bladder cancer for decades has been to give chemotherapy with a drug called cisplatin plus gemcitabine, followed by cystectomy to remove the bladder. We know that in a subset of patients, when the bladder is removed and analyzed by a pathologist, there's no more cancer left in the bladder, and that's called a pathological complete response. A pathological complete response is associated with a very favorable long-term prognosis. However, we only know that information after the bladder's already been removed. And this has raised the concept, could we determine which patients have had their bladder cancers eradicated with a transurethral resection of the tumor by a urologist plus systemic therapy like chemotherapy without having to remove the bladder, and thereby offer this as a bladder-sparing treatment paradigm. So we set out to test this concept in a prospective clinical trial. We used that standard chemotherapy, but we added an immunotherapy drug called nivolumab, which has shown to be an effective part of the treatment regimen for patients with metastatic bladder cancer. We gave 4 cycles of this combination treatment, chemotherapy plus immunotherapy. And then after that, patients underwent a series of studies. They underwent imaging of their bladder to see if there was any tumor that was visible on CAT scan or MRI. They underwent urine cytology to look for cancer cells in the urine. And they underwent a cystoscopy with their urologist, a scope of the bladder with biopsies of the bladder. If there was no evidence of cancer on those investigations, then patients were offered the opportunity to proceed with standard treatment, which would be to remove the bladder, or to not have their bladders removed and undergo an additional 4 months of immunotherapy alone. The trial was designed to determine what the complete clinical response rate was with this regimen, meaning the absence of any cancer that could be detected on those investigations after treatment, and to determine whether or not a complete clinical response predicted which patients remained long-term free of cancer with an intact bladder. The trial enrolled 76 patients. At the time of the data lock, 64 of those patients had completed the 4 cycles of treatment and had undergone that series of investigations. Among those patients, 31 patients had no evidence of cancer on those investigations, a complete clinical response rate of 48%. Our follow-up of those patients is still somewhat immature. It's a little bit more than a year, but among those 31 patients, only 1 patient chose not to have, not to be followed with observation. Only 1 patient chose immediate cystectomy to remove their bladder. And in that case, there was a very low stage cancer residual. In the 30 patients who opted not to have their bladders removed so far, we have many patients out beyond 1 year who have had no evidence of recurrence of their cancer and whose bladder remains intact. So in summary, a transurethral resection of bladder tumor by a urologist plus systemic therapy with chemotherapy and immunotherapy in this clinical trial was a feasible approach, led to a relatively high clinical complete response rate, and demonstrated that in a subset of patients, long-term bladder intact disease-free survival is possible. But this trial requires much longer follow-up to ensure the durability of those responses in patients whose bladders have been left intact. And so this is not yet a standard approach that should be applied without longer follow-up, but potentially one day will be part of our standard treatment approach to muscle-invasive bladder cancer. Thank you for your attention.